Hi, everyone. Welcome. My name is Maggie, and I'm one of the alumni directors on the National APAMSA board. On behalf of National APAMSA, we're super excited to have everyone join for the 2026 Bootcamp series. And this is actually, I think, the first year that we have a neurology bootcamp. So thank you, everyone, for being here, and thank you for taking the time to all the speakers. This series is hosted by our alumni residents and faculty, and it's designed to cover high-yield topics for incoming sub-interns and interns for any given specialty. But just in general, it's like really helpful for anyone on clinical rotations or anyone who's interested in learning more about a specialty. Do you mind going forward, I think, 2 slides? This is just an overview of all of the bootcamp sessions. We have 11 total this year, which is really exciting. And if you're interested in attending any of the other ones, you can register on the APAMSA site. The link is here on the slide, and the registration links are also published on all of our social media. And you'll probably continue to see them being pubbed as the weeks go on. Today's neurology bootcamp is the last one of this week. But we have lots of amazing talks coming up in the next 2 weeks, so don't miss out. And with all of that said, I'm going to pass it off to Dr. Ray who actually started the original bootcamp series, to say a couple more words and welcome you all.
Hi, welcome everyone. My name is Ray Hu. I am one of the alumni leaders and former presidents of National APAMSA. I am so excited to welcome you to APAMSA's Neurology Bootcamp. This is our 8th annual bootcamp and the first time that neurology is featured, thanks to our stellar residents and attendings who have stepped up. Neurology is truly an extraordinary specialty. The precision of a careful neuro exam, the intellectual thrill of localizing a lesion, watching a stroke patient regain speech, these are experiences that are unique to this field. And with the explosion of many disease-modifying therapies and MS, epilepsy, and other neurodegenerative disease, I think this is a very exciting time that you guys have chosen to either go into neurology or having some kind of interest in neurology from a medicine standpoint. So I'm very excited to see what our speakers will teach us about today. I'll hand it over to our star medical student specialty section leader, Ha Young An.
Hi, everyone. As our previous colleagues have mentioned, thank you so much for being here. Really excited to kick off the neurology boot camp. I'll just talk about a few logistics for how the session will go. So we really encourage participation and interaction throughout. Please ask any and all questions that come to mind, even if you want to ask for clarification on topics. We have our wonderful speaker panel here today, and they're really excited to teach you. So while the presenting resident is speaking, the remaining speakers will answer any questions you have in the chat as well. And if you'd like to ask a question through voice, you can also raise your hand and we'll be on the lookout for that too. Okay, so with that said, I'm so excited to introduce our speakers for today. We have 4 amazing resident physicians who represent the field of neurology, and we are going to have each speaker cover a particular section of today's boot camp. So I'm excited to present Dr. Athena Dr. Athena Dong. She's a PGY2 at USC. And is she available? Hi, could you just share a few words about yourself?
Hi everyone, thanks so much for being here. Yeah, my name's Athena. I'm a neuro second year currently at USC. I am interested in going into neuropalliative care, and then like behavioral neurology and dementia in the future. So I like chatting with my patients and I like spending a long, long time with them, but I don't like LPing them. Other interests, I'm really interested in community health. We do a lot of work at the county hospital here, and then also like education for trainees, and then kind of cultural differences in neuropalliative care.
Awesome. Next, I'm presenting Dr. Jennifer Lin, a PGY3 at Cornell.
Everyone, I'm so glad to be here. I'm Jennifer. I'm a PGY3 at Cornell. I am currently applying into headache medicine. And in terms of my interest, I'm interested in like medical education. I'm on our medical educator track at our program. Also pretty interested in like medical humanities and community health. And other than that, just really excited to be here. I was one of the former regional directors when I was a med student. So it's been really great to make this kind of 360.
Awesome. Thank you for being here. Next, we have Dr. Joyce Lee.
Hi, everyone. So great to be here. My name is Joyce. I'm currently a PGY2 at UCLA in neurology. I've been heavily involved in PAMSA for the last decade or so already. I'm also at one point the national president. I'm very excited to be able to actually start off this neurology boot camp for the first time in its history. I'm very interested in neurocritical care or stroke, but do eventually want to go into neurointerventional radiology as well. So I'm very, very happy to be able to present today.
Thank you. And finally, we have Dr. Allison Zhong.
Hi, everyone. Also very excited to be here. I'm Allison. I'm a PGY4 at Mass General Brigham right now. And I will be doing a neurorehabilitation fellowship next year at UCLA. So I'll be taking care of all of Joyce's patients when she's done with them. Also very interested in medical education and medical humanities like everybody else here.
Wonderful. And we're so excited that these are also APAMSA alumni who have come back to really give their time for you all today. So we really appreciate their involvement even after med school has been finished. Okay, so this is the agenda for today. As I mentioned, each speaker will cover a broad section or topic. And so we'll go from the foundations all the way to inpatient consults that you might see, especially as a lot of us here in the audience might be starting sub-Is in the summer or starting our residency. And then we'll talk about neurological emergencies, and then we'll cap it off with outpatient neurology. So now I will hand it off to our first speaker, Dr. Athena Dong.
All right, hi friends. I am on service today, so we're going to try to get through as much of this as we can before the code pager and inevitably goes off. But I'll be starting out talking about the foundations of neurology, so exam, what to do when a patient is encephalopathic, and then some basic neuroimmunology labs, and a very quick run through of neuroimaging. Alrighty. So starting with the neuro exam. So you guys are probably familiar with the steps of the neuro exam, and I would encourage that when you're performing the exam, with each element, think about which systems and structures within the nervous system are being evaluated. Think about how could this function in those systems or structures manifest, and then what pathways are involved. Something that I really struggled with when I was first starting out as a resident was being overwhelmed with like exam findings and thinking, oh, I don't know like the formal vocab word or the medical terminology to describe what I'm seeing. And that is totally, totally okay. That is very normal. You are going to learn everything as you progress through your training. I would say if you don't know the exact word for something, no one is going to fault you for that. Just describe what you see. So that way, when you go back to the note, if someone else goes back to the note, they know exactly what to look for. So we'll go through the steps of the neuro exam in a little more detail. With regards to mental status, so level of consciousness refers to the patient's state of arousal. You may see people refer to patient's level of consciousness with the words delirious or lethargic, somnolent, stuporous, obtunded, comatose, but these words are not super precise. They mean different things to every person. And so again, when in doubt, just describe what you're seeing. So if the patient is not awake, can they be awakened by voice or stimulation? And then is that wakefulness maintained or do they fall back asleep right away? And then you can also get a really good idea of mental status just while taking the history. So our exam takes place throughout the entire conversation. For example, when you have patients with Parkinson's, you're looking at their tremor and things like that during the exam too. Okay, and then with regards to cognitive functions, so ways to test attention, you can do your reciting, spelling, serial sevens. Inattention to half of the world is called neglect. With regards to memory, you're looking at short-term and long-term memory. Patients might demonstrate retrograde or anterograde amnesia. Language-wise, you're looking at production, so speaking and writing, comprehension, which would be hearing and reading, and repetition. Language deficits are called aphasias. And then praxis is your ability to perform complex learned motor tasks. Also, in some patients, you might look at abstract reasoning and visual spatial processing. With regards to the cranial nerves, so ways that we would test all of these nerves, starting with cranial nerve 1, you could do a test of smell. My hospital has like these little lemon drop things that they keep in the supply room to test smell. Your hospital may have something different. We don't often test cranial nerve 1 in the hospital, but it's always there in case you need it. For number 2, you're going to look at the pupillary light reflex, which tests the afferent pathway, which is cranial nerve 2, and the efferent pathway, cranial nerve 3, and the connecting pathways. Also make sure that you check visual acuity and visual fields, and you can also visualize cranial nerve 2 itself with the fundoscope. Okay, moving on to 3, 4, and 6, you'll do movements of the eyes, elevation of the eyelid, and pupillary constriction. Also, don't forget to check saccades and check if the patient is capable of smooth pursuit. For cranial nerve number 5, facial sensation to light touch, temperature, pain, as well as strength of jaw opening and closure. For cranial nerve number 7, we look at movements of facial musculature. Make sure that you're checking upper and lower, especially in the case of trying to differentiate like a Bell's palsy or a peripheral 7 from a central 7. With regards to 8, that's just hearing in both ears. 9 and 10, we'll look at articulation of speech. If there are any issues, we call that dysarthria. We look at speech volumes. For example, if someone speaks very quietly, we would call that hypophonia. And then swallowing, so dysphagia would be an issue with swallowing. Also look for palate elevation and gag reflex. For 11, check shoulder elevation. That would help you check your trapezius, and then head turning will help you check the sternocleidomastoid. And then for 12, just protrusion and movement of the tongue. Okay, so moving on to the next sections. Motor-wise, the motor exam is great because it tests every level. So you test the brain, brainstem, spinal cord, ventral nerve roots, peripheral nerves, neuromuscular junction, and muscle. Make sure that you're thorough in testing the strength of all muscle groups. And you're not only looking for weakness, you're also looking for differences between the left and the right side, so asymmetry. So make sure that you're checking for bulk. If patients have low bulk, we call that atrophy. Look at tone or rigidity. You can look at speed of movement. So in patients with Parkinson's, for example, they will have slowed movements. We call that bradykinesia. And then any abnormal movements such as fasciculations or tremors. Overall, in terms of vocab words, weakness is referred to as paresis, and then complete paralysis is called plegia. So, for example, weakness of both legs, we would call that paraparesis. Paralysis of both legs is paraplegia. Weakness on one side of the body is hemiparesis, and then paralysis of one limb is going to be called monoplegia. And then with regards to the sensory exam, just a couple notes. I put in a little dermatome chart that is going to be your best friend. Make sure that you test all sensory modalities, the distribution of sensory loss, and which modalities are affected help you localize lesions of the sensory pathways. So if you're testing pain, you can use a pin, you can use the end of a Q-tip. We have these things called neuro needles. For vibration, you can hold a tuning fork to a joint and then ask the patient not only if they can feel it, but also how long they can feel it for. So how long does it take them to lose the vibration sensation? And then for proprioception, you can move a joint up or down. You've probably learned to do it with the big toe, and then ask if the patient can identify the direction or movement with their eyes closed. You can also assess for the Romberg sign here. Proprioception, if you're not familiar with it, is just referring to perception of where the body is in space. Okay, and then last parts of the exam. Every part is important. You need to be thorough with the exam. The exam helps you get your diagnosis most of the time, and like imaging labs or ancillary. But reflexes, so reflexes test the nerves and the roots that provide sensory input to the spinal cord and those that receive motor output from the spinal cord. And they also test the interconnections between the motor and sensory pathways. So if there is a lesion in the peripheral nervous system, reflexes might be diminished. We call that hyporeflexia. or they might be absent. We call that areflexia. If there is a lesion in the central nervous system, we might see increased reflexes, so we call that hyperreflexia. One tip I have is that some patients have a lot of trouble relaxing fully for you to get their reflexes. If you can't get reflexes, try using a reinforcement maneuver. So an example of that is if I'm testing the patellar and Achilles reflexes in the patient and they're having a difficult time relaxing, I'll tell them like focus on like making a fist with your hands or doing some movements with your hands. So that will distract them a little bit. Reflexes are graded 0 to 4 plus. 4 plus denotes hyperreflexia with clonus, which is a rhythmic oscillating movement at a joint. Some of you may have seen it before. Once you see it, you will know to identify it from then on out. It's pretty distinctive. And then hyperreflexia may also be associated with the phenomenon that we call spread. So what occurs then is that eliciting one reflex leads to simultaneous activation of adjacent reflexes. And then don't forget to look for pathologic reflexes because those can also tell you a lot of information. So you can look at the Babinski sign, which will tell you about any central nervous system or cortical spinal tract lesion. You can do a Hoffman sign and then frontal release signs. Those are ones that I use most commonly day to day. For coordination, my tip is look for ataxia, which refers to uncoordinated movements. Look for dysmetria, which is inaccuracy of movements. And then look for dyseidokinesia, which is uncoordination of your rapid alternating movements. One tip I have for finger to nose testing is just make sure that the target, so your finger, should be far enough away from the patient that they have to fully extend their arm to reach it. This also gives you a good idea if they have any weakness or tremor too. I think usually we feel and we think of coordination as involving just the cerebellum, but the cerebellum needs proprioceptive input to perform its coordinating function. So ataxia can also be caused by impaired proprioception, and we would call that sensory ataxia. And then moving on to gait. So gait relies on optimal function of all levels of the nervous system, so it is a really good test. A couple of gaits that maybe you'll see with your patients commonly, you might see something called a steppage gait, in which the foot is lifted high off the ground and then gets slapped down. This is usually due to weakness of dorsiflexion causing foot drop. You might think of Trendelenburg gait, which you probably learned about in anatomy as well. In this one, the pelvis drops towards the opposite side when weight is balanced on the leg of the affected side, and this is due to gluteal muscle weakness. You can have in Parkinsonian gait. Usually patients will have a stooped posture. They'll make small steps. They'll have a shuffling, walking, and some difficulty turning. There's magnetic gait, in which the feet are lifted only briefly off of the ground before being returned briskly to the ground, often seen in NPH or proprioceptive dysfunction. There's ataxic gait, which is wide-based and unsteady, often due to cerebellar dysfunction or severe dysfunction of your proprioception. And then in the spastic gait, the leg will be extended, the foot will be plantar flexed, and then the entire leg may be circumducted. So that means it's swung out to the side with each step. And that's usually due to central nervous system dysfunction. If both of the legs are spastic, this can lead to something called a scissor gait. Okay, another thing that I also found challenging in the beginning of residency was walking in to examine a patient and they are comatose. And I would just stand there and be like, well, there's not really much I can check, so what can I really do? And I felt very lost. But there are actually a lot of things that you can examine even if a patient is comatose or altered. So what I like to do in the ICU, for example, is I look at before the exam what drips the patient might be on and checking if they're on sedation. I always ask the nurse or the primary team if it is safe to pause sedation to get a neuro exam. So things that you can look at, level of consciousness will adjust. So look for any potential signs of arousal. So visual fixation, visual pursuit, which we sometimes call tracking. If you try to open the patient's eyes, do they try to keep their eyes closed? Are they resisting you? And then how are they able to follow commands? Can they follow everything, just a couple things, only things in the axial area, or only things in the appendicular area? For brainstem exam, just make sure that you're being careful if the patient is in a C-collar or has traumatic injury. You may need to defer some steps of the exam. For cranial nerve 2, we can adjust it and look at voluntary eye movements and visual pursuit. as well as blink to threat. You can look at the pupils and light reflex. For 3, 4, and 8, you can test with the oculocephalic maneuver, which is also called the doll's eye test. For 5 and 7, you can test the corneal reflex. And then for 9 and 10, you can do cough and gag. Especially if they're intubated, that makes it easier for you too. Motor-wise, sometimes patients will respond to light touch in terms of sensation as well, but other times you'll have to apply painful stimuli to the fingertips and sometimes the face. It will feel really bad the first couple of times you do it, but don't be shy about it. You're trying to get a good exam. You're trying to get an accurate exam. So most patients, I usually will go and like pinch the edge of the finger at the cuticle, or I'll try to like tickle feet, to try to lift their arms or legs up, see if they're maintaining it at all anti-gravity. If you have grimacing without withdrawal to noxious stimuli, then that means your sensory response is intact, but you might have some degree of motor paralysis. If you have flexion in the extremities, you may have heard of the term triple flexion, but no grimacing, no reaction to the pain itself, then we get concerned for brain death or very severe brain injury. If there's asymmetry, just as it would be in a perfectly alert patient, we worry about a focal lesion. And then response to pain, kind of going from greatest response to lowest response, you have localization, then you have withdrawal, you have flexor posturing, which is decorticate posturing. You have extensor posturing, which is decerebrate posturing. And then you'll have no response or triple flexion. That is the worst one that you'll get. And then also look for any spontaneous movement. And then again, any anti-gravity movement. Okay, everyone's favorite consult, altered mental status. No matter what field you go into, you're either going to be experiencing this, you might be placing a consult to neurology for this. Patients have a lot of reasons to be encephalopathic, and the etiology is not always neurological, but it seems that we tend to get consulted for it anyway. It is one of the most common consults that you're going to get. So my suggested approach to this is, with regards to the history, ask about the timing of onset, the progression of the severity, and any fluctuation in mental status, any previous episodes, recent drug use or new medications, any pain, constipation, urinary retention, and issues with sleep quality, and then any history of hepatic, renal, or endocrine conditions, and then any history of seizure. On the physical exam, things I add on to and on top of whatever I'm already looking at, I look for any sort of signs of trauma, any asterisks, so like the flapping hands that you see with hepatic encephalopathy or myoclonus. Look at volume status, look for any signs of incontinence or tongue biting that might suggest seizure. And then any nuchal rigidity, fever, or gross focal neurologic deficits that would make us worried about something like meningitis. And then the differential is very, very broad. I will put in the meeting notes so that you guys can access kind of the very broad differential that I like to look at. But people like to use a mnemonic. Here's an example of one. So things you look at are toxic metabolic, any issues with oxygenation, vascular disease, and then endocrine issues, neurologic, things that we look at most commonly, seizure, stroke, post-ictal state, any tumor or meningoencephalitis, any bleed or hydrocephalus, and then any other inflammatory or neoplastic process taking place in the central nervous system. You can also look for signs of shock, as I mentioned before, trauma, infection, and then any psychiatric factors. Don't forget that a lot of times for patients who are in the hospital for a long time, they can have delirium from being in the hospital environment too. And then with regards to next steps, you can grab a broad set of labs, usually checking, of course, your CBC and CMP, checking endocrine function, infection, and then nutritional labs is usually what I like to start out with. If there's concern for infection, of course, grabbing cultures of the urine and the blood. Imaging is really a case-by-case basis, and other diagnostics are also very case-by-case. So you could do something as simple as a chest x-ray. You might end up grabbing a CT head or MRI, and then in some cases you might want to go ahead with an EEG or a lumbar puncture. And then making sure that if there's concern for Wernicke's encephalitis or meningitis, that you're providing appropriate coverage for those things. And then something to just keep in mind is that sometimes patients need a little more time to recover. They need that tincture of time, especially if they have a poor cognitive reserve to begin with. Okay, so a brief overview of CSF analysis and then some labs that you might be looking to order. So when you're doing a lumbar puncture, your senior tells you, okay, make sure that you put in the LP labs and then go ahead and do the LP. And then you're lost and you're like, I have no idea what I'm supposed to order. I don't know what I'm doing. So basic labs, you want to look at pressure. So opening pressure, closing pressure. Elevated CSF pressure is usually due to any process that can raise intracranial pressure, so intracranial hypertension. And then accordingly, decreased CSF pressure could be due to intracranial hypotension. CSF glucose might be decreased in bacterial, fungal, or tubercular CNS infections or with leptomeningeal metastases. CSF protein could be elevated in any inflammatory or infectious state, or when there's obstructed circulation of the CSF due to spinal lesions. Elevated white blood cell count in the CSF can occur due to CNS infection, inflammation, and hematologic malignancy. So I recommend that you use flow cytometry to characterize the white blood cell count populations and to evaluate for malignancy. And then elevated red blood cell count in the CSF could occur in a traumatic lumbar puncture, but the thing that we definitely don't want to miss is a subarachnoid hemorrhage. Okay, and then special cases, you might be asked to order things like oligoclonal bands. These are a non-specific marker of CNS inflammation. They denote intrathecal synthesis of IgG, and they are very commonly assessed when you're evaluating for multiple sclerosis. And then a lot of times you will evaluate for any antibodies in the CSF that could be associated with paraneoplastic syndromes of the central nervous system. And these are often more sensitive than the serum evaluation, so usually we'll send those as well. And then with regards to putting it all together, when I was first starting out, I really like to use a chart to interpret my CSF results just to try to figure out what I'm looking at and narrow my differential. There are more information-dense charts out there, but this one is good for a quick reference. So common patterns of abnormalities that you might see elevated protein with no or few cells. We call that albuminocytologic dissociation, and that is a non-specific indicator of an inflammatory process. You might have elevated white blood cell count and protein with normal glucose. That would be concerning for a viral issue. And then elevated white blood cell count and protein with a low glucose is concerning for a non-viral infection. The most extreme values are seen with bacterial infections of the central nervous system. All right, so moving into neuroimaging. So why do we need neuroimaging? What does it add for us? So it helps us visualize the structures of the neuraxis, and then it helps us extend our neurologic examination. So if you recall what I said earlier, you can learn a lot of things from the exam. A lot of times you can make a diagnosis based on the exam itself, but imaging can often be helpful if there are any questions or you're trying to narrow your differential. And then also imaging helps us provide additional information about any underlying pathologic processes. So when you're looking at imaging, think about, do the imaging findings correlate with the clinical presentation? Are there any aspects of the clinical presentation that do not have a neuroimaging correlate? And then are there any incidental findings that have no relationship to the current presentation, but might require further evaluation or longitudinal surveillance in the future? And then just keep in mind that neuroimaging has to be interpreted in the context of a patient's history and exam so that you're not misinterpreting radiologic findings. So overall goals of neuroimaging: identifying normal structures and any disturbances or distortion. So asking yourself, is everything there that's supposed to be there? And does everything look how it's supposed to look? And then identification and characterization of any abnormal lesions. So is there anything there that should not be there? And if so, how can it be characterized? And neuroimaging will seem very daunting when you first start out, and this is another thing that really just comes with practice. Look at as many images as you can, talk about it with your attendings and your seniors, and things will come with time. As a neurology resident, you are expected to, and you should be reading at least a preliminary view of your own scans. Radiology may miss things, or sometimes it takes radiology a while, especially overnight, to put a read in, and sometimes you need the results of the scan earlier than that. My tip is that when you're opening an image, look at the image yourself before reading the radiology report. That also helps you with your practice. So suggested approach to looking at imaging on CT, usually things that you'll look at will be brain matter, so looking for any masses, any abnormal attenuation, any mass effect. You'll look at the subarachnoid space and the ventricles, looking at size, looking for subarachnoid hemorrhage or hyperdense MCA sign. You'll look at the gray-white differentiation, which can indicate cortical hypoattenuation, can sometimes indicate infarct or anoxic brain injury. You'll look at blood and the subdural spaces for any subdural hematoma or extradural blood. Look at the soft tissues for any focal lesions or hematomas. And then don't forget to look at the bone for any fractures or destructive lesions. So with regards to MRI, couple things, just an approach from my end. There are a lot of sequences and you will learn with time which ones are most appropriate to look at in each setting. But quick overview, T1 is good for an anatomical overview. T2 is good to look at the basal cisterns, look at the ventricular system and the subdural spaces. The FLAIR is really good to assess white matter disorders, and it's probably one that you're going to look at very frequently no matter what neurological pathology it is. DWI has many purposes. I most frequently use it to identify ischemic stroke or active demyelination. And then the SWI can help us identify blood products or calcification. Couple mnemonics that I like to use. So if something is white or bright on DWI and then dark on ADC, it's concerning for diffusion restriction. And so most commonly we think, oh, is that representative of an acute ischemic stroke? And then there are mnemonics to help you determine the age of blood on MRI. I won't go too deeply into it, but there's a really good page on Radiopedia that helps you age the blood and with several mnemonics that you can consider using. And then the big question of when to use contrast. Contrast can further improve the sensitivity of your neuroimaging in detecting abnormalities, and it can improve the specificity with which the etiology of those abnormalities can be determined. Enhancement of the meninges or the parenchyma, which is abnormal, suggests breakdown of the blood-brain barrier, and that's what allows contrast to leak into those tissues, and that gives you the contrast enhancement. So often I'll order contrast if I'm looking for tumor or infection or inflammation. So just quick overview of which ones to order. The way I like to put it to patients when I'm counseling them is that CT is really great in the emergency setting. It's done very rapidly. It's good for identifying any acute intracranial hemorrhage. And then MRI is higher resolution, but it takes longer. In your residency, you'll experience that a lot of patients understandably have a lot of anxiety in the MRI machine. So it may be a challenge to get MRI as opposed to CT. The MRI gives you some more sequences to characterize abnormalities and is more sensitive for overall any subtle findings and also findings in the posterior fossa, which are not visualized super well on CT. Okay, and then a brief word on vascular imaging. The one that you're probably going to use the most as a neurologist are going to be CT or MR angiography. We use these to look for any sort of vascular malformations or occlusion, dissection, vasculopathy, any sort of atherosclerotic or stenotic disease in the vessels. This one you'll look at every time you have a code stroke. You're looking for a large vessel occlusion that could be chased after with thrombectomy potentially. But then there are some other other imaging modalities that you might use, which I've listed here. Quick word on CT perfusion. This is another one that you often use in the case of stroke. It helps us determine how much tissue might be salvageable or whether or not to go ahead and proceed with the thrombectomy. So key things that we look at are cerebral blood volume, which is the amount of blood in a region of the brain. We have cerebral blood flow, which is the volume of blood moving through a region per unit time. We have mean transit time, which is the average time for blood to traverse a given region. And then we have the ischemic penumbra, which refers to tissue that is ischemic but not yet infarcted. And that's something that gives us a lot of info on whether or not to pursue thrombectomy. All right, that was a lot of words. I am going to return to service, but please feel free to contact me. I'll leave my contact information in the chat in case you guys have any questions at all. Thanks so much for joining.
All right, hey guys. So this is Jen. I'm gonna be talking now about a couple things. Oh, 1 second. Do I have control over slides? Just double check. Okay, perfect. So I'm gonna start off with talking about kind of general principles, like that you'll obviously run into and like get better at as you get further along in your training. So like part of that greater autonomy approach. So like talk about triaging. And then I'm going to present a framework for some common consults, specifically headache and dizziness. These could be sections in and of themselves. And At the end of the day, the more consults you see, the more volume you see, the better you get at like developing that schema. And then also finally talking about some other like pearls regarding anything about disposition and workflow tips, which will be really helpful both during your time as a neurology resident, as well as during your first year when you're mostly doing internal medicine. And then Altered mental status, of course, is a very common consult. So you can refer to the prior presentation for that. All right. So first I want to talk about triaging. So thinking about when you're a neurology resident, obviously like when you start out as an intern, you should have some more guidance as far as like who to see first and such. But the big picture is of the next few slides is like patients to see like ASAP versus like patients that you have a little bit more time to see. This becomes especially important when you get like say multiple consults at once and you're the only neurology resident in-house. So big picture, see ASAP slash stat, like anything that could compromise the patient's safety, very time sensitive, or allow them to be a candidate for acute interventions. So obviously stroke codes, see ASAP. If they're actively seizing, anything that compromises their airway, breathing, circulation, and more to come on like the management of this in our neurological emergency section. Other big pearls is always look at your images yourself. Even if there's a final radiology read, you always have to make sure you like check and then confirm as well because sometimes things can be missed. And then finally, you can always ask for help from your seniors. I'm of the philosophy that it's better to be like safe than sorry, and especially early on in your training. And this goes like across both like internal medicine as well as neurology. You can always like ask for help from those around you, as well as like your attending and from other team members. So let's present like a scenario, and this might be one that might be kind of familiar to those of us who've like recently come off of neuro consults. I was on nights this past week, for instance. So the pager goes off a couple times. You get a consult that says this physician has severe headache, nausea, vomiting. That's like written in the one-liner. The second one is first time seizure, and then the third one says stroke on imaging. So you're in-house and you're trying to figure out, who am I going to see first, right? Um, so again, and the big picture is again, first of all, like have going and calling back these like consults and kind of getting a sense like are they actively seizing for that patient who had a first time seizure. That's really important to know. Other like things, could they be a candidate for acute intervention, like is there something intervenable? So if I see something like severe headache, nausea, vomiting, right, like I want to know like did it start like pretty recently, like are they do they have any deficits? Is there something intervenable? Because there are certain red flags that you'll come across in terms of symptoms that make you more or less worried. And really, I'm thinking about, is like, what's the worst thing that could happen to the patient, right? Severe headache, nausea, vomiting. Could they be having a bleed or a stroke? Especially if it's in a more acute timeline setting, and if they have any neurologic deficits. Other than that, when the person who's reaching out to you is consulting you, like they should be able to give you a pretty good one-liner in history with the question and pertinent symptoms. But sometimes you'll run cases where the question's a little unclear, so you can always ask and clarify a bit further. And then other than that, you're kind of thinking again about what kind of diagnoses or is on your differential and like what kind of treatment. So like as you get further along in your training, like even before you see the patient, you're already thinking about, what kind of workup am I doing, and what else has already been done. All right. So I've called back, these consults and they said this person has severe headache, nausea, vomiting. It started 5 hours ago, so it's pretty acute. Cannot walk, pretty disabling. They have some vascular risk factors and there's no imaging available. So I'd be like, okay, I'm on the web, let's see them ASAP and maybe put in like a code stroke, right? And then I got a little bit more information about those other consults. I checked are they actively seizing? No, they're back to neuro baseline. The ED already gave them a little bit of empiric Keppra. Their CTI is negative. Their labs are pending. So I'll say like I'll see them, but maybe I'll see them in a little bit. Okay. And then stroke on imaging. Say this person got a CT head because they've been like a little waxing waning altered mental status and resulted overnight. Um, as I mentioned, you look at your imaging yourself. So you quickly scroll through, maybe as you're running down to see the first patient, and it's like a tiny little punctate lacuna infarct. So you'll say, okay, let's see them in a little bit, and we'll go from there. So I just want to switch gears now to talk about headache, with specifically an inpatient focus. When people consult you about headache, uh, uh, it could be from many different causes. In the hospital setting, the biggest thing that comes up is they're trying to like make sure, is there any further workup or imaging that needs to be done? And then, of course, you'll have those cases where it's someone's having a classic migraine exacerbation, which I won't focus on as much. I think that's covered a little bit more in the outpatient neurology section, but I'll touch very briefly on management of that as well. So this is a pretty common mnemonic for like red flags for secondary headache. It's called a Snoop 4. There's like a version of it that's called Snoop 10. And essentially, it's something that is done, applied in like the outpatient setting, but also very useful in the inpatient setting. And some people have like mixed opinions about mnemonics. I'm someone who kind of can't remember all the different parts of Snoop 4, but I think it's still like helpful to put this out there for those of you who might find it useful. So the S stands for systemic symptoms. Are they having like fever or anything else that could be concerning essentially for like a giant cell arteritis presentation? Or maybe is it like are they like infected? Are we concerned about meningitis? Obviously, if they have like new neurologic deficits or dysfunction, that is something that's concerning that would push you more towards wanting to image them. Onset, if it's like sudden or abrupt, again, we're thinking about, are you worried about a bleed? Are you worried about some other like acute pathology in the brain, right? That would push you towards imaging. Older age, specifically like 50 years or older. It's pretty uncommon for someone who's older to suddenly develop a new primary headache disorder. So that's always a red flag. And then I'm usually using the P4 because like the P10 just has way too many parts, but essentially anything else that you gather in your like history and physical, which I'll talk about a bit further, that could be concerning. So changes in like the pattern of the patient's symptoms. If it's positional, like worse with like sitting up or always worse with laying down. If it's precipitated by certain activities, and then if there's like papilledema, those last like three parts are all like hitting at something called changes in intracranial pressure, which can cause things like positionality and then like issues with like physical exam findings such as optic disc blurring, which could be a sign of high ICP. And then often, and I'll put in like in parentheses, but number 5 is pregnancy. I do a lot of consults for the hospital across the street. But pregnancy is a hypercoagulable state. There's a lot of other physiologic changes, so we usually have a pretty like low threshold to image patients when they're pregnant because like many things can go wrong. So as I mentioned, like I don't really know that many mnemonics. So my way of kind of like breaking this down like in a big picture setting, that might be helpful for some of you guys, is thinking about the brain and its surroundings, right? So you have the brain parenchyma right here on the top left, and then there's blood vessels, and there's also veins, and then there's also the cranial nerves and the meninges, right? So all of that is part of this like of your head. And again, like in a hospital setting, you're kind of focusing on like thinking about secondary causes of headaches, really caused by any disruptions in this equilibrium. So if there's something wrong with the blood vessels, something wrong with the meninges, something wrong with like the CSF, etc., that can all cause secondary headache. And there's kind of this related concept that is called like Monroe-Kelly doctrine. I won't go into too much detail about it, but essentially it's this idea that the brain, like the cranial compartment itself, is fixed. So like any expansion of one section, whether it's like we have a tumor, for instance, and it's expanding, right? It's causing displacement of the brain parenchyma. And to some degree, your body's able to compensate like by displacing blood and CSF. But at some point, then there's a sudden decompensation. That's when you get issues with intracranial pressure, and then that can lead to pretty devastating outcomes such as herniation and so forth. So taking a step back again, just thinking about like approach to like the headache history and physical itself. A lot of it comes back to the basics that you've already like know about in medical school. Thinking about old carts or like Socrates, whatever mnemonic you use. You really want to take a comprehensive H&P, like timing, tempo, what kind of quality is a headache, when did it start? Is there any other person in history? Like how frequently are they happening? Any other associated symptoms? Some big things to make sure you cover is asking about positionality, because that's one of the things that's on that like red flag list. If it's worse with lying down or bearing down, you're thinking like potentially considered for high intracranial pressure, right? Again, thinking about that Monroe-Kelly doctrine and so forth. Versus the conversely, if it's always worse with sitting up, you can think of low intracranial pressure, because like the CSF is all like causing like the brain to sag. It causes like meningeal irritation. And then otherwise, you go through your neurologic review of systems, you do your general exams, see how they look. Vitals are important, because if their blood pressure is super high, that could be causing headache through like hypertensive emergency. And then the neuro exam, and then some other focused exam pearls. You want to make sure you palpate the temples, the jaw, the neck, as well as the spine. Those can all be areas of like referred pain from headache. And then in something like giant cell arteritis, you might have temple tenderness. And then also always doing a phonoscopic exam. Even if you're not very good at it, you'll get better at time. And look at the visual field to see if there's any concern for high like ICP. And then in terms of assessment plan, it really depends on if you find any red flags. If yes, then I would say like I need at least a CT, non-con, and then plus or minus like some kind of vessel imaging, depending on what your differential is. And then usually I start from like less to more invasive. So thinking about imaging, and then also thinking about something more invasive, like do they need like a lumbar puncture? We talked about the CSS studies, but this is especially important if you're concerned about like a secondary cause of headache, like meningitis or something with like high intracranial pressure. Of note, it's really important to ensure it's actually safe to tap someone before you stick a needle in the back, because that can cause herniation if there is like something in the brain itself that could come down when you're tapping them. And then also thinking about other like inflammatory markers, for instance, thinking about like giant cell arteritis again. And treatments really kind of depends on, what you really find. This is a very dense slide, but you can feel free to take a look at this later. It's just for reference, but like just like showing examples of how you can use that systematic like H&P approach to figure out, treatments for various types of causes of secondary headache. Okay, and then again, like if we ruled out secondary causes, then like what do we do? So things you can do is give like something called a migraine cocktail, which is like fluids, mag, antiemetics, and then like other types of common acute treatments like steroids, Depakote, and then think a little bit more about long-term follow-up as well for these patients, because them being in the ED is like a good way for them to have to get connected with neurology care in the long term. And I've like encountered some examples of that during my own training. Okay. And then next, I want to talk about the other like very common consult that we get is for dizziness. I actually don't mind dizziness consults, but I know that it's something that can be very nerve-wracking for a lot of people. Again, like you gotta do your comprehensive H&P. So again, like say similar to the prior like headache framework, you gotta ask about the timing, the tempo, like are there any other associated symptoms? When did this come on? So doing your basic history. Some other important pearls though is that you also want to like get a sense of like what makes it better or worse. Is the like dizziness positional or is it like always there? And I really emphasize like trusting the patient to use a word other than dizziness because I say dizziness means different things to like different people, and there's really four big buckets. You'll find that like vertigo tends to be the one that like freaks people out the most because again like in the ED setting they're trying to figure out is this a stroke or is it something else, right? But you'll also be able to ask them about try to characterize it into like these three other buckets, which is lightheadedness, like when feeling woozy or generally disconnected from the environment, disequilibrium, which is like when they're feeling off balance or unsteady, and then presyncope, like feeling like they might pass out. So really try to hone into like what does the dizziness mean? Like if you can use a different word, like is it spinning? Do you feel like blood's rushing out of your head? Because that's going to guide your eventual like thought process as to further workup. Objectives wise, you do your neuro exam. How do they look? Do they look really bad? It's actually, interestingly, for both peripheral and central causes of vertigo, they can like look pretty bad with nausea, vomiting. But again, you do your door test, and then some things I really think are important, especially for the dizziness exam, is try to do something called like a Dix-Hall pike if they're having vertigo to see if you can like bring out that vertigo when you move their head in certain directions. And it's a little tricky to do, but because I actually didn't know this existed before residency, but there's something called a HINTS exam that can also be helpful for like distinguishing between central and peripheral causes of vertigo. And then for your other parts of your exam, like you can check for coordination, looking for like cerebellar signs, see if they're walking, how are they walking, and then also doing a Romberg to check for like sensory deficits, which could be helpful with like this equilibrium. This is just a slide about how to do the HINTS exam. Honestly, it's probably easier to actually look up a video of like how it's done. And your mileage will vary. I think like these exam maneuvers, they can be helpful, but ultimately I realized that in like practice, especially if you're at like a very like high like resource like center, we tend to just like have a low threshold for like imaging people's brains, like if they have like any concerns about vertigo, even if it seems kind of peripheral. But for like the hints, there's like three parts. There's a head impulse test where you take the person's head and you turn their head really quickly to one side or the other, and then you're trying to see if there's like a corrective saccade. So if their eyes kind of bob back, if the eyes bob back, that's actually more suggestive of like a peripheral etiology, versus if they don't, then that's more suggestive central. And then you look for nystagmus, which is pretty straightforward, seeing if the eyes are bobbing. Multidirectional nystagmus is concerning. You can get nystagmus with like peripheral vertigo as well, like with BPEV. And then also doing test of skew, which actually I haven't like seen the positive version of this yet, but like theoretically when you cover like one eye or the other eye, like if the eyes are misaligned, it's more concerned for essential etiology. So again, like kind of vertigo is like kind of I think my main focus for a section. Peripheral vertigo, we're thinking like positional. We're thinking correctness of saccades and the hints. We're thinking if you do a Dix-Hall pike, the person's gonna get like super dizzy. And it's very dramatic. Like I'll lay like the person back and then turn their head to the affected side. They'll be like, whoa, 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 whoa! I'm so dizzy. But the cool thing is that if you have a little time to do an Eppley maneuver, it's like kind of like can work like magic. They're like, whoa, I feel so much better. So that's really exciting and very satisfying. Otherwise, you can think of other peripheral causes, like anything that affects the vestibular like system, like vestibular neuritis, Meniere's, etc. And then the big thing is like, vertigo is definitely something that like stroke codes are activated for a lot, or just dizziness in general, because this is something that, could be time sensitive. Like the biggest concern would be if there's some sort of a posterior circulation pathology going on. And then like typically it tends to be more constant, less like positional. Another thing is that you'll do your stroke scale. But there are some limitations because like if you look at the components of the stroke scale, like it doesn't really capture uh, uh, the the posterior circulation systems that well. I mean, I think there's like you get like some points for like dyspmetria and such, but it's really can be a little confounded by that. And then also like the CT head is often not as good for visualizing like the posterior circulation in terms of like changes. And then other than that, kind of things I talked about, like red flag, like neurologic deficits, dyspmetria, like cerebellar symptoms, those all make you more concerned for like a central cause of vertigo. And kind of the others, I won't go into as much, but lightheadedness, kind of feeling woozy is a little non-specific. You might consider like psychiatric or like other systemic causes. Pre-syncope, thinking, like the syncopal workup. Maybe it's vasovagal, maybe it's like cardiogenic, maybe they're orthostatic. And it's attached into your medicine knowledge as well. And then disequilibrium, again, like kind of like looking at other parts of their exam, are there any other like sensory deficits, how's their motor? And that can influence whether you want to recommend further imaging. Okay. And then this is a kind of segueing back to kind of general workflow. So we talked about triaging, we talked about, okay, you saw some consults. Let's talk about just general disposition and thinking about, how am I going to take care of this patient, right? When you're in the ED, like, the big thought is like, are they safe to go home? This means, is there any further tests or workup they need? Like, do they need that MR brain? How are they doing in terms of their ADLs, the activities of daily living? Do they need someone to evaluate them? Is there any other like intervention they need, like anything that requires them to stay inpatient? And are there any other like social or safety factors that we need to account for? These are all things that you need to keep in mind, like regardless of specialty, really. But especially like when you're doing these consults, because that's like the big picture plan. And like really, if you're thinking about this early on, like not only will the rest of your team be pre-impressed, but it's just part of good patient care. You're also thinking about, what kind of level of care do they need, right? My person that I'm concerned, like, might be like actively like hemorrhaging in their brain. They need ICU, right? Versus like, this person with like maybe an incidental little infarct on imaging, maybe they have no deficits on exam. It could be like floor status. You see, really, I got to be mindful of this kind of stuff when you're seeing patients. So pictures of things that can keep a patient in the hospital, right? Like in neuro, we often see strokes, and strokes can cause people to have trouble swallowing. You can't send the patient home if they need an NG tube, right? If the NG tube falls out, then who's going to put it back in? So they have to be able to have some way of getting nutrition, right? Can they walk, right? Like sometimes, even if you think it's like peripheral vertigo, which is like mostly supportive care, if the patient can't walk, then that's like a problem, right? They've got to be able to like, like not fall and be able to go home and do their activities, right? And then, is the patient like requiring any like medications that require like inpatient treatment, like, like systemic anticoagulation. Even like the diagnosis itself, if I'm concerned for someone with like a high risk PIA, which you'll learn about more with like something called the ABCD2 scoring system, they have a higher risk of having a stroke in the next few days. So we usually like admit them for expedited monitoring, even if they look okay otherwise. And again, you can always like ask for help. Obviously, like as a intern and like early resident, you're going to be running these cases by like someone higher up. But again, it's really good to just be really mindful about thinking like what is going to keep this patient in the hospital, right? Can they walk? Can they eat? Like, what do they need? And say, I've gone through all this stuff and they don't need to stay in the hospital. Let's say, they it's a consult for a headache and I've ruled out secondary causes. And they're maybe getting better after I gave them like a migraine cocktail. You got to think about like, okay, do they need to see neurology outpatient or not? Like, and then if they do, like how soon? Like what kind of neurologist? Like 2 to 4 weeks from now, sooner than that? Obviously it can be kind of hard to get like a quick neurology appointment, but at our institution we try to do our best to get people connect as soon as they can. what kind of like meds would you recommend giving them? Like, is there any other like non-urgent pending workup? Um, uh, because as a consultant, like it's really important to like have close loop communication. So, when you're communicating these recommendations to ED, always, make sure like you get feedback. This also applies for like the inpatient setting, right? When you're communicating and signing out patients to the incoming doctor, it's really important, like especially in neuro, like make sure they have like an updated exam. Make sure we're reading back and double checking orders, and just working as a team. Yeah. So here's an example of a sign out, right? This person's a watcher. They're 85-year-old woman with 3 days of like right side of weakness. We found on imaging to have like embolic strokes. She's I need you to follow up on blah blah blah. And if she worsens, like here's her exam, then like please get a repeat CT head. All right. And then this is just another slide just for like some helpful resources. Really like neurology is all about like learning about cases and not being afraid to like reach out. I have a short attention span, so I don't really read that many books, but I have found like some texts like decision making in adult neurology to be helpful because it has like mostly flow charts for like different consults, radio PDF for like images, and then really just learning from those around you. At our residency, like we often for common consults have like dot phrases. Obviously, you have to think about each patient individually, but that could be helpful for like figure out what to do next. And then finally, just don't be afraid to go back to the basics and review your neuroanatomy because that's where it really comes in play.
Okay, that was super awesome. Thank you so much for going through that. So we're at the halfway point of our session right now. And with that, I'm gonna give you all just a 5 minute break. We can all like get up, get some water, go to the bathroom. And in the meantime, we can get started after the break is over. Okay, so I think we'll go ahead and resume our session. Next up, we have two more sections for the next hour, and it'll be more amazing content. So we're really excited to have our speakers take off the next two sections.
Hi, everyone. Thank you so much for sticking through the remaining two sections. So I'll be going over some neurological emergencies, which is mostly seen on the inpatient setting and also in the emergency department. I'll be going over stroke, including both ischemic and hemorrhagic stroke, seizures, especially with status epilepticus, and also some spinal cord compression and neuromuscular emergencies as well. So the first section I'm going to go over is stroke. I think one of the most important things that you can do as a resident, also as a sub-I, right, is to actually identify why someone is having a stroke, and then like what symptoms comprise the patient's disease of the stroke. So remember, the most important thing that we always talk about is time is brain. The quicker you're able to recognize the symptoms, the faster that you're able to intervene on these. So there's a good mnemonic that we actually share a lot with our patients. It's called B fast. So B stands for balance, so any sudden loss of balance, and this can also be due to acute vertigo. Eyes in terms of losing vision, so any kind of large field cuts where all of a sudden they're not able to see out of one side of their world. Face for any kind of facial asymmetry, arms for any sudden weakness in the upper extremities or lower extremities as well. Speech in terms of like changes in how they're speaking, in terms of are they now sounding like a drunken sailor, or are they now not being able to make any sense with the kind of speech that they're producing. And T is always standing for time. So again, the quicker you're able to identify these symptoms, the faster you're able to treat them. So let's say like a patient comes in with a sudden loss of vision in one half of their field, and they're also unable to move their arm, and they're also aphasic. What do? You want to activate a co-stroke. So from neurology standpoint, by the time we're actually involved at this time, the patient had already had a co-stroke that's activated. However, let's say like you're an intern, you're a sub-I, you're pre-rounding on your patient, and all of a sudden you kind of notice these symptoms. And you're like, oh shoot, like what should I do? Like, should I tell my senior? Should I just activate a co-stroke? I would just activate a co-stroke no matter how small the symptoms may be. The worst thing that can happen is the patient is completely fine, they don't have a stroke. But the worst case scenario is that you did not activate a co-stroke, things get missed, you then go on with walking around with the rest of your team, and the patient had discompensated at that time. So I always say activate it when you can, and you'll be able to kind of rope in all the help that you need from the neurology team and also from the rest of the hospital, including pharmacy, nursing, and also transport too. So here are just a few examples of things that we do during an active co-stroke. A lot of things are going to be happening simultaneously, so these are not really happening in a specific order or not. Okay. So once you activate a code stroke, you want to also assess the patient's airway and breathing. So remember always your ABCs, because regardless of the stroke, if the patient's breathing and airway are compromised, you're going to want them to be intubated regardless. Next is their circulation. I always want to get an EKG or at least a 12 lead on, so that I can monitor the patient on telemetry. Also want to know what the blood pressures are, just because it's going to impact management. The next thing is I also want to get rapid labs, point of care glucose, and also some initial labs, including coags as well. And then you're going to want to think about what kind of imaging you want to get. So depending on your institution, it may be a CT first, or it might be an MRI first institution. But for me, as a rule of thumb, if the patient is rapidly decompensating, they say like now, in addition to the initial symptoms they had, they're now losing consciousness. They're not talking anymore, and they're also having airway compromise. I'm gonna have to go to CT first. They're not going to be stable for MRI. And of course, you also want to do a rapid neurological assessment, initially with the NIH stroke scale, which has all the different components, are pretty good at picking up like large vessel occlusions. But remember, the things that you want to actually keep in mind is that you only need actually a point of care glucose and a non-contrast imaging to rule out bleed before you can actually start any kind of thrombolytic therapy. So kind of going to ischemic strokes, when you're kind of going through the workup of this and kind of getting to know the patient, you most importantly want to know what the patient's last known well time is. And I always tell patients, I always tell their family and also the providers, the last known well time is not the time where the symptoms were observed. It is actually the time where the patient was normal, right, at their baseline. And that, the time that they give you as to say, like, let's say, at 10 a.m., the patient was walking and talking, completely fine. That's their last known well time. But then, like, by 11, they're like, oh, they're now not able to walk, they're not able to talk, something's off. That's the symptom onset time, so not the last known well time. You also want to get a pretty basic, like, HPI from the providers and also from the family. And the patient, they're able to talk to see if they're on any blood thinners or any kind of different past medical history that's going to eventually, affect your plan and also your treatment options too. And again, I just want to reiterate, if the last well time is within 4.5 hours, you're already starting to think about the candidacy for IV thrombolytics like TNK or TPA. I mentioned large vessel occlusion signs. These are LVO signs, and these are some things that I always want to keep in mind when I first get the page about the patient, and also things that I'm looking for as soon as I enter the patient's room. The reason why this is so important, especially if the patient has a last known well time of within 24 hours, is that they may be a candidate for mechanical thrombectomy. So the acronym that I like to use is FANG-D. So F is for the field cut. So all of a sudden they cannot see the entire left side of their vision or the right. A is for aphasia. This can be both non-fluent aphasia and also fluent aphasia. N is for neglect. So again, they're all of a sudden not, regarding one half of their world, and this can be in different modalities. It can be to sensory, it can also be to vision, or if they have a gaze evasion, which is the G, and then D is a dense hemiparesis. Of note, what's important is you actually don't need to check all of these boxes in order for a patient to have a large vessel occlusion. So for me, as soon as someone is coming in with one of these symptoms, I am alerting the appropriate teams to let them know that this patient may be a candidate for mechanical thrombectomy. And then again, you want to do a rapid NIH stroke scale. I'm not going to go into too much details here, but there's an MB Calc app that you can use with the NIH stroke scale that you can just kind of hit all of the appropriate responses, and there are also different stroke apps that you can use. Earlier in my training, I have to pull up the app all the time to kind of remind myself, what components of the NIH stroke scale I need to go through. However, like once you're really confident with doing stroke codes, you actually can do them from memory. It's possible, trust me. And just to reiterate again, ABCs are super important. if the patient has an LVO sign, but then again, they're not able to protect their airway, they're rapidly decompensating, their vitals look awful, you will prioritize intubating the patient. You don't have to wait to get a neuro exam before a patient is intubated if that is going to help save their life eventually. Okay. You also want to go through stat imaging. So for LVOs, especially, you want to make sure that imaging includes vessel imaging as well. But again, depending on the institution you're at, some people prefer CT first, some other people will prefer MRI. And then you usually get vessel alongside that. And also, as most institutions, they also want to do a perfusion imaging as well. And of course, don't forget to rope in your senior, don't forget to rope in your stroke fellow. And then, of course, sometimes don't forget to rope into your attendings. All right, so some of the treatments that we're considering for ischemic stroke, again, is TNK or TPA. TPA was usually the standard of care. However, now with TNK being rolled out, more and more hospitals are prioritizing it over TPA just because it's easier to administer. You could just push it. You don't have to kind of do like a slow bolus over time. So the patients last on well against within 3 to 4.5 hours or less than that. There's certain criteria that people have to make between the 3 and the 4.5 hour mark. MD-Calc actually has a great calculator to essentially decide if a patient has any exclusion criteria that they meet where they would not be able to get TNK and TPA. So you can use that too. But usually this treatment is indicated for people who have disabling symptoms. So we usually estimate that this means the NIH stroke scale of at least 4, but it's subjective to the patient, right? So if the patient is right-handed and their NIH stroke scale is only a 1 for like a mild drift in their arm, but it is to the point where they cannot work as an artist, technically they can still qualify for a TNK TPA. And then after a patient is given this IV thrombolytic, they must be admitted to the ICU for closer monitoring for at least 4 hours. They have strict blood pressure measurements that we have to take into account to prevent a bleed from happening. And then the other kind of therapy that we do in the acute setting is the mechanical thrombectomy. And again, last on well time is within the first 24 hours. Depending on the proceduralist, they sometimes have some leeway with that too. In this instance, you do need to get vessels, you do need to get perfusion, because what the proceduralists are actually looking into is to make sure that there's actually salvageable tissue. The occlusion, even though I gave you the FANG-D acronym, sometimes patients can actually have posterior circulation, large vessel occlusions that don't really necessarily fit that FANG-D acronym symptoms. Loss of consciousness, decreased level of consciousness, those are some things that we can also look into as well to consider a patient for thrombectomy. And same thing with acute vertigo, kind of like what Jenna was talking about. If they meet any of the criteria for a central etiology of vertigo, we also go through the same thing, getting perfusion studies to make sure that the patient doesn't have a large vessel occlusion in the basilar artery. Most of the times when people are kind of considering a patient for eligibility for a mechanical thrombectomy, they do want an NIH stroke scale of at least a 6. They do have other clinical trials going on to see if patients with a lower NIH stroke scale can also benefit from a mechanical thrombectomy, or if medical management is going to be decent enough to kind of help patients recover. After a thrombectomy, again, the patient has to be admitted to the ICU for close monitoring. You want to keep the blood pressure normal tensive to prevent any bleeds from happening. There are usually requirements for post mechanical thrombectomy imaging. At UCLA, we do a 3-hour imaging with an MRI with and without contrast, and also with the whole stroke protocol. And we also do another 24-hour imaging at this time. Reason being is that you're able to kind of rule out any bleeds. You can assess, if the patient had reoccluded, if the patient had any like further development or evolution of the stroke. For any of these patients, you should get a CT head if the patient had any change in their exam, or if they had a sudden spike in their blood pressure, just because patients are at risk of bleeds after getting either of these treatments. So you want to be very careful in making sure that you're checking for any kind of worse outcomes from these two different interventions. So let's say you finished going through a post-stroke, patient stable, they got the appropriate treatments, or they're now being admitted and monitored. The next steps on the inpatient side is we're always thinking what caused the there's a post criteria that we use that essentially kind of goes through the different etiologies of stroke, just because the etiology of stroke matters in the terms of how we're going to eventually take care of this patient and what are the actual management in terms of treatment for this patient kind of going forward. The five main categories are you have a large vessel occlusion, so this can be due to patients having very large plaques, this is like in their common carotid artery, their internal their intracranial carotid artery, and people will need to be on antiplatelet therapy for a very long time. Other etiologies are small vessel strokes. These are tiny little punctate lacunes, sometimes in the thalamus, most likely there in the basal ganglia. These people are getting strokes because of high blood pressure. They're getting strokes of diabetes. They're getting strokes from also elevated LDLs as well. They also need to be on antiplatelet therapy. And in terms of people with cardioembolic strokes, these are people with AFib that have been untreated, right? And then their CHA2DS2-VASc score is high, but then they're not on any anticoagulation. This is when you will start a patient on anticoagulation like Eliquis and also like Xarelto. And then you go into different categories where you have cryptogenic strokes, where you're not really sure where that stroke is coming from. This can be from a hypercoagulable state, let's say from cancer somewhere in the body that the patient just has not been worked up for yet. And then you have also embolic strokes of undetermined etiology, so undetermined source, so ESIS. So this is also a different kind of category of stroke where the management of it is going to be a little bit different from others. So let's say you did all the workup for the ischemic stroke, and then now the patient, has a brain bleed. What do you do? So how do you even identify a brain bleed? So of course, there are symptoms. Again, changes in their consciousness or just new focal neurological deficits. When you have high concerns for a patient with a bleed, you want to get a CT immediately. You're going to see a hyperdensity on the CT, and if you go into MR, you can also see active GRE signals or SWI signals on the MRI. They usually come out as hypointense or dark or black on the MRI sequences. So I just put a picture here of the different kinds of bleeds that you can see. For us at UCLA, if you get a post-stroke and people have these specific brain imaging findings, a lot of times it's actually neurosurgery that's going to be the ones taking care and managing them. Other times they want stroke to be involved or neurology to be involved just to see if there's any underlying etiology of stroke or the hemorrhagic stroke. So what do you do if a patient has a bleed? You want to reverse the blood thinners from the get-go, or also if the coags came back, there's some discrepancies, you want to reverse them right away. If the patient is on any kind of antiplatelet, you want to consider giving them the platelets back. So you give them DD-ABP, plus or minus actually platelet infusions. If they have been on any kind of heparin, you can give them protein sulfate. Warfarin, you want to think about vitamin K, also Kcentra. And if for the Bigatran, you want to give them something called abrucizumab, or if they're on factor 10A inhibitors, you want to give them adexanate alpha. The thing that you can do as a resident is just make sure the head of bed is elevated right away, greater than 30 degrees. You also want to make sure that their blood pressure is not too high. So our goal is always, any systolics under 140 is what we kind of aim for. We can use IV labetalol to drop it down, or you can just start them on a cardine drip. Of course, with any kind of brain bleeds, you want to just inform the neurosurgery team to see if there's any interventions they can do, and also page the ICU or neuro ICU teams. All right, so that's pretty much an overall overall map of what strokes look like in the inpatient setting and also when you get consulted. So I'm going to shift gears and talk about seizures. The seizures I'm going to go over is mostly going to be what you're going to get on an inpatient setting. I'm not going to talk into the more so like the outpatient management of patients with seizures. I believe we're going to talk about that later on. So the most important thing for seizures, I think, is to recognize when a patient's actually in status. So status is actually defined as you're having continuous convulsive seizure activity for greater than 5 minutes, or you have 2 or more convulsive seizures without full return to baseline between seizures. Same with stroke, you always want to look for ABCs first. If a patient has been seizing for 5 minutes and they're not back to baseline and they're still seizing, they have secretions, they cannot manage it, you have to think about having to potentially intubate the patient. And a concurrent kind of a management with the seizure activity is you want to get, again, vitals, glucose. You want to make sure to have like 2 large bore IVs so that they can give IV fluids. You want to get imaging just to see, is there any underlying sources of seizures, right? A brain bleed is the biggest reason for patients having like a first-time seizure, especially if they had a trauma. So you want to get a CT head to rule out bleed. And then you can also get an MRI when the patient is more stable, right? And then you can also get a clear imaging when the patient stops seizing, they're still, they can actually sit through an MRI. At different institutions, you can also get an EEG. So there's a really quick, really bad EEG that we could do, but super fast. It's called a Cerebral. It's literally just a helmet that you can put on the patient. And then the fellow can usually interpret a read super fast from that. You can also get a more formal EEG on an inpatient setting that's continuous if that's available at your institution. And then finally, the next thing you want to think about is, what kind of abortives do you want to give this patient and what kind of like long-standing medications you want to give them. So going just briefly into seizure management, the first line medication we use is an abortive, right? These are patients who are seizing. After 5 minutes, they're still not breaking it, or they start having clusters of seizures. You want to break those seizures. So we start with benzodiazepine. Ativan or lorazepam is probably the most available medication you can give. You can give a 2 to 4 milligram IV push. And we usually want to just give 2 milligrams per minute at the max rate. And then you can also then redose the patient as needed afterwards. In terms of diazepam, there's also a dosing that you can use. Diastat also comes in different forms. There's intranasal, there's IM, there's also rectal diazepam that you can use as well. Midazolam, same thing. So let's say now, you give the abortive, but the patient's still not breaking the seizures. What can you do? So there's actually something called a 60-40-20 rule that we kind of memorize as neurology residents. This has to do with the thing of the load that you're going to give a patient with these medications. So levetiracetam is Keppra. This is the most commonly used medication. We dose them at 60 milligrams per kilogram, and you kind of start doing a maintenance therapy for them at around like 10 to 15 mg per kg every 12 hours. People sometimes still use Depakote and fosphenytoin. I want to say, like, I personally just haven't loaded patients with these just because technically Keppra, Depakote, and fosphenytoin, they're all kind of like equivalent in terms of their efficacy, as that's what the trials have shown. But you can dose Depakote at 40 mg per kg as a loading dose, and you start them on a maintenance of 4 to 6 milligrams per kilograms every 6 hours. But just note that this does affect platelets. So in patients with thrombocytopenia, you definitely do not want to give them Depakote because that can worsen their platelet count. Fosphenytoin is also another one. This one doesn't actually have a maintenance dosing. Just load them once, 20 mg per kg. If there's no use, then you redose them again another time. Phenobarb, some people use as well. I personally just haven't really used it in my training. Lacosamide or Vimpat is actually another common one that we would usually use too. For this one, it does affect the PR interval. So I always get a pre-Vimpat EKG to see if the PR is prolonged. If they're safe, then I will give them a one-time dose of 200 or 400 milligrams IV. Then I will start down on maintenance with 200, 300 milligrams every 12 hours. And I usually will get another EKG after the patient has been on certain 200, 300 milligrams every 12 hours. Okay, so if none of that worked, now you're kind of going to the danger zone of a status epilepticus. This is when you will definitely consider intubating, definitely considering talking to the neuro ICU or the medicine ICU. This is because this is when you're going to start going to different kind of drips that are going to further decrease the patient's level of consciousness. So the third line agents we use are like, the seizures lasting for 30 to 60 minutes. You want to start them on a Versed drip. You can use this if the blood pressure is unstable, which is a good thing that you want to kind of consider. You want to load them first with the 0.2 mg per kg, then you repeat every 5 minutes until seizures stop, and you kind of keep escalating that dose up to a maximum of 2 milligrams per kg. The maintenance dose of it is usually 0.1 to 2 mg per kg per hour. Propofol is also a great agent too. You load with 1 to 2 mg per kg, and then you repeat every 5 minutes again until you're escalating a dose until the seizures stop. And then you usually have a maintenance a dose of 2 to 10 milligrams per kg per hour. If you treat patients with propofol on a drip for more than 48 hours, you don't want to increase it too much, just because it does have side effects. You also want to get a triglycerides as a baseline before you start the infusion, just because it can cause hypertriglyceridemia. So that doesn't work. You're going to like la la land of seizure management. These are times where the neuro ICU at this point is going to be throwing a lot of different agents that we as residents at this time really probably isn't going to be comfortable managing. So this is going to be up to your neuro ICU fellow, up to your neuro ICU attending. These seizures at this time will most likely be just electrographic seizures, just because you are already sedating them, and they're not going to be actively generally shaking. But this is when they consider like a pentobarb coma, which can cause hypotension, meaning that you're going to need to have pressors at bedside, which is why they need to be in the ICU. But this is also when people start adding 3 or 4 different anti-seizure medications just to make sure that they keep the seizures at bay. And this includes clobazam or Onfi, includes topiramate, Topamax, and then perampanel as well. So that's a pretty brief overview for seizures that you're going to see in the hospital, and also seizures that are leading into like this status epilepticus and having to be managed in the ICU. So I'm going to just go over the spinal cord emergencies. So the big things about spinal cord emergencies to be able to recognize what are the red flags. This may be due because this can lead to spinal cord emergencies. There's a pretty fun acronym that they use called tuna fish. So trauma, unexplained weight loss, neurological findings. Age is a big component of it, just because the etiology of the spinal cord emergency is going to be different. If it's for fever and chills, to rule out kind of meningitis, as for the patient being in an immunocompromised state, which makes it a little bit more into getting infections, if they have long-term steroid use, or if they have a history of cancer. So the first kind of bucket I would talk about in spinal cord emergencies is any kind of acute myelopathy. This can be acute to subacute to also progressive as well. Symptoms may vary. Most likely is weakness, some numbness, but you can find hyperreflexia or increased tone. The etiologies are numerous. You can just see a brief overview of what kind of different etiologies there are, but they're mostly under the bucket of inflammatory, vascular, spondylitic, metabolic, or other causes. The imaging of this is going to have to do with like an MRI spine with and without contrast. Depending on what kind of symptoms they're seeing, you may scan different areas of the spine. And then the treatment, again, really kind of depends on the different kind of etiologies here. The next kind of bucket you want to think about is any kind of acute cord injury. So these you're kind of thinking more so as like traumatic causes, right, of spinal cord injuries. It could be fractures, especially older folks who can get spontaneous, compression fractures. You can also have disc herniations, spinal hematomas. The spinal cord injury sometimes mostly relates to local pain. They also would have absent reflexes. In males, you can actually get priapism, and then you can also get urinary retention and bladder dissensions in both sexes. And you also can have some neurogenic shock where your vitals are going to be different. Imaging for this, we actually would go for an X-ray first, especially to kind of rule out any kind of compression fractures. You can also get CT just because they do view the bones a little bit better than MRs. If the patient is stable, you would then eventually also do an MR of their spine. We always ask for an ADC, a DW and an ADC, just to kind of rule out any kind of spinal cord strokes we can happen to. And at this point, you will also consult a neurosurgeon in the ICU so that they can, or they can be transferred to a spinal cord injury institution center ASAP. Finally, the last kind of categories I have for spinal cord emergencies is conus medullaris versus cauda equina syndrome. I have a diagram here that kind of separates out, the different areas that we would consider as it being a conus medullaris compression versus a cauda equina compression. So for conus medullaris, it usually affects T12 to L2. Sudden bilateral symptoms can again vary. Can be both upper and lower motor neuron size. They do tend to have a little bit more back pain. They would complain of saddle anesthesia, but they have retained bowel and bladder and sexual dysfunction, sexual function. Cauda equina syndrome, they affect the nerve endings of the spinal cord, and it's pretty gradual and usually unilateral. They're kind of similar to the symptoms you would see in a conus medullaris, but the radicular pain is usually a little bit more severe. In terms of imaging for both of these, you would get an MRI L spine with and without contrast, and you can sometimes write in the note, for the radiologist and the techs to say like you have a concern for this kind of injury. For management for these urgent neurosurgery consult, you want to give them steroids to calm down inflammation. You also want to give some analgesia as well. So my last section is on neuromuscular emergencies. So neuromuscular emergencies are fairly rare, but it's definitely things that we will be able to see, especially on an inpatient setting. And sometimes you will commonly see a patient being sent from like neuromuscular clinic, neurology clinic, with concerns for neuromuscular emergencies. So some of the most common causes we see is actually myasthenic crisis and GBS progression, which is what I'm going to focus on here. So the most important thing you want to look out for in both of these things is airway protection. When a patient comes in, you want to, again, manage your ABCs. You want to also see how their vitals are doing. However, something that's unique to this population is we actually want to get something called the NIF or the MIP. So this is the negative inspiratory force or the maximum inspiratory pressure. And of course, you also want to do a physical exam on these patients too. So negative inspiratory force, and it's also AKA the maximum inspiratory pressure. It actually measures the maximum strength it takes for your respiratory muscles, especially diaphragm, and it records the highest negative pressure a patient can generate during inspiration against an obstructed airway. So this is usually done by the respiratory therapist. A normal NIF is anything less than 60. Okay. When you're starting to consider patients need to be intubated or the ICU needs to be alerted about this patient is when their NIF goes between -30 up to 0. The closer you are to 0, the higher the risk of respiratory failure. And one thing that you guys all have to know is that you can totally see normal pulse ox even with patients with poor NIFs, especially in patients with neuromuscular etiologies and pathologies. You want to make sure that you're actually trending the NIFs. So depending on their first one, you can then decide if you want to trend the NIFs like every 2 hours or every 4 hours or every 6 hours. Other bedside tests that you can do for patients with myasthenia, you could do a single breath count. You have them take in a couple of deep breaths, and then in one breath, they're going to count probably like 1 to 2 numbers per second and see how high of a number they can count to. Normal-ish, is anywhere between 30 or 50. If they're only going to be able to count to like 15, that's bad. That it's a good indication that they have a low force vital capacity and also an indication of respiratory muscle weakness. For GBS patients, they usually have a rapidly progressive, like facial bulbar weakness, which you can tell by testing their cranial nerves. One of the difficulties they have is like they're unable to lift their head. And these are all predictors of eventual respiratory failures. So for both of these patients, you also want to think about other kind of warning signs for the ICU. If their FVC is less than 1 to 1.5 liters, which is around like 20 cc's per kg, that's also a poor indicator of the respiratory function. And again, their NIFs, if they're greater than -30, if their vitals are labile, because some of these pathologies can affect their autonomic system, that's also something you want to look into too. And also, if their speech, all of a sudden, they're not able to have full conversations, they're often having to take a break and breathe. That's also a poor indication. And finally, if they're unable to clear their secretions, these are all signs for the ICU. An elective intubation is much better than an emergent intubation. Patients with either of these pathologies, the discussion about intubation has to be had from when they get to the hospital, even before that. Treatments for either of them. So PLEX or plasma exchange or plasmapheresis, usually 5 sessions. This is a rapid treatment that you can give to either of these patients, but you will only have a transient improvement. So it probably can last like weeks. This is preferred in patients who are most likely in the ICU already with a respiratory distress. And this is usually reserved for patients with more critical severe exacerbations. If PLEX doesn't work, then IVIG is usually considered as well. And this can also be considered in patients with less emergent cases, but you won't kind of see the improvement for IVIG until like weeks after. It works slowly over weeks again, but it's usually dosed at 2 grams per kg over 2 to 5 days. If you're considering both treatments, do the PLEX first and then the IVIG, because if you do IVIG first, the PLEX is just going to wash out the very, very expensive IVIG that you had already given. Steroids may be used later for maintenance therapy after PLEX or IVIG. And this is something that's going to be a joint medical decision to be made. And this is specifically for patients with myasthenia. So just some tips and tricks for everyone. Always learn about your specific institution's guidelines in terms of managing any of these neurological emergencies, just because a lot of them are variable depending on where you are. Inpatient neurology, can be scary, especially, when you first get started, you're getting those code strokes, you know what to do, but definitely lean onto your seniors, rope in people that you can call and help from. And with practice, hopefully you will develop that confidence over time. Eventually, maybe you will even think that it's fun and want to go into either stroke neurology or neurocritical care. So I want to wish everyone good luck. I'm going to hand it over to Allison.
Awesome. Thanks so much, Joyce. All right, it looks like I have control of the slides. So I'm going to be talking about the opposite end of the spectrum. So we're going to outpatient neurology now. I'm going to quickly cover some outpatient skills and approach, since I feel like this is not something that I really got comfortable with until the last 2 years of residency. And then I'm going to try to breeze through talking very quickly about outpatient management of headache, tremor, neuropathy, cognitive complaints, and epilepsy. A lot of my slides will have a lot more information than what I'm actually going to say out loud. So hopefully you guys can reference back to either the video or the slides when we send them out. All right, so quick approach to outpatient neurology. How do patients end up in neuroclinic? We kind of referred to this earlier, but you will often get patients who are inpatient or ED consult follow-ups that are sent to your clinic. Other ways they might end up in your clinic, they might be sent by their PCP or other subspecialties, and sometimes they can do self-referrals as well. I think the big thing to remember when you're thinking about evaluating your neuro patients in clinic is that not all problems that come through clinic are neurologic, and not all patients with neurologic problems really need a neurologist to follow them if they're very stable. So part of your job is figuring out if they actually have a neurologic problem, and if they do, if they need to continue to follow up with you or if they can go back to their PCP. Really quickly with the workflow, I'll just highlight that I think it's very different from inpatient, where time management is very key because you have a limited amount of time in your appointment and your slots are going to be booked up for the whole day. So you really want to focus early on, I think, on getting a good history and physical, and then later, as you get more comfortable with things, you can spend more time answering questions and doing counseling with your patients. And then you can always kind of go back and finish things up after the visit is done. And then just some tips and tricks that I think I've picked up throughout the years. Getting to know your local resources and teams really well is really important in neurology because it's such multidisciplinary care. So knowing some of the support groups and foundations that operate in your area, any specific names of neuro-focused therapists, for example, somebody who might focus on stroke or somebody who focuses on functional neurologic disorder, they will have very different approaches. But if they have a particular area of expertise, your patients can really benefit from that. And then getting to know your clinic support staff so you can kind of message back and forth with them. They can be really helpful to you in contacting patients and organizing things for you. Learning how to interact with insurance and pharmacy, super important for those prior auths. Not every location is going to have people who can help you with that. So kind of trying to figure out how to manage that. And then I think one big thing is learning how to manage your inbox. Your patients are going to be sending you messages all the time, and it's not feasible to always respond right away. So kind of being able to set those expectations and figuring out how you want to go about that as a provider. And then I think the other thing to remember is that they still have like a provider team even when they're outside of the hospital. And so being able to communicate with the rest of their team is also really helpful. And you will have more visits if you need them. So you don't have to answer everything all in one visit. You can always save some things for the later visits. All right, so we are going to go to headache. We're going to talk mostly about outpatient management of headache now. So let's say you've ruled out all the secondary causes of headache, your patient's coming to you with some kind of primary headache disorder, trying to figure out which one it is. The three big types that you're going to be dealing with are migraine, probably one of the most common ones that you'll see, tension headache, and then the last one is often taught in med school as cluster headaches. But it's kind of under this larger umbrella of what we call the trigeminal autonomic cephalalgias, and that includes cluster headaches, paroxysmal hemicrania, hemicrania continua, and Sunkton Suna. And the reason differentiating these is important is because the management is very different. So you're going to be thinking about the duration of these, the frequency, are they unilateral or bilateral? Do they come with other features like photophobia, phonophobia, nausea, or auras, or do they come with like autonomic features? And those will help you kind of differentiate between these different types of headaches that you might be dealing with. I'm going to talk a little bit more about migraine management because this is by far the most common thing that I think we get in neurology clinic that we end up consistently following. So when we think about migraine management, we think about two different things. We think about the abortives or the rescue medications when they have a migraine attack or a migraine flare. And then we think about the preventive medications if somebody has enough headache days per month, then we start thinking about starting them on a daily medication to help kind of decrease the severity and the frequency of their headaches. So as far as abortives go, there's a few different options that you have. You have over-the-counter medications. This is your Tylenol and your Advil. You just have to be careful with counseling that you can get medication overuse headaches if you use these too often. So patients have to be a little careful with that. You can do an oral version of the migraine cocktails that we talked about when we were talking about inpatient headache management. And then triptans are probably the most common abortive that you will see prescribed, and the most common ones among that being sumatriptan and rizatriptan. And then we have a newer kind of category of medications that we can use for abortives, which is the CGRPs if people have contraindications to triptans. So this is going to be Ubrelvy and Nurtec. And then for preventives, the first line medications that you're going to be using are beta blockers, anticonvulsants, and tricyclics. I think most insurance companies still require you to fail 2 of these before you can do a CGRP because they're newer and more expensive. But the CGRPs are often very nice for patients. So among the CGRPs, there's some oral versions, which are Nurtec and Qulipta. And then there are injectables, which is like a monthly injectable, which some patients really like. And that's going to be the Aimovig, Emgality, and Vyepti. And these are all like probably the kinds of things that you guys see like Lady Gaga advertising on TV. So lots of people really like them, but you can't jump to them straight away. And then the other thing to just keep in mind is that there are some procedures for headache management as well. So there's Botox for migraines that you can get every 3 months. And then you can also do occipital nerve blocks or trigger point injections And oftentimes people with really bad migraines need some kind of combination of a lot of these things to help manage their migraines. I think in terms of counseling for headaches, one big thing that I like to tell my patients is to keep a headache journal. There's some really great apps out there now, like Migraine Buddy, but this is really so that they can identify what their triggers are and help try to avoid them in order to help manage their headaches. And then for women, you want to consider whether they're catamenial. So if they happen like at some point during their regular cycle, you can kind of try to manage that as part of the management of the migraines. And then I think one big thing is setting expectations. So oftentimes your patients will not be able to be completely headache-free, but you want to make sure that their frequency and severity are manageable. So setting that expectation for them. And then letting them know that their migraines will change over time. They'll change in frequency, they'll change in severity, depending on what's going on in their life, and they may even change in semiology. Okay, so with headaches, we're going to move on to tremor, another very, very common outpatient consult. So when you're evaluating tremor, there's a few things you want to pay attention to. You want to pay attention to the location of the tremor. Is it in the hands? Is it in the head? Is it in the legs? And then also the laterality of it. Is it bilateral or is it unilateral? And then you want to think about the amplitude and the frequency. So is it like a high amplitude, like low frequency tremor? Is it like a high frequency, low amplitude tremor? Those are going to clue you into different types of tremor. And then you want to determine whether it's a resting tremor or an action tremor. And among action, you have kinetic tremors. So when they're doing something, they get the tremor. Postural tremors, if they're holding their arm up, does the tremor come out? And then intention tremor, if you're doing finger to nose, for example, does it come out towards the end? So you're going to evaluate multiple different positions. I will often have them like hold their arms out and then like hold them bent. You can have them hold up their hands as well to try to help evaluate when this tremor is coming out. And some more specific evaluations you can do are asking them to write things. The Archimedes spiral is really helpful. So you can see there's like a normal one on the left there. And then in Parkinson's, there's less of the tremor component, but it's much smaller spiral that they're drawing. And then with essential tremor, there's often like a specific axis that their tremor will be on. So you can kind of see like all the squiggles are going in the same direction. And then the dot approximation test is like you draw a little dot and they hold a pen above it and you see how the tremor comes out when they do that. I think it's super helpful for movement disorders to look at videos of these things. So there's a link to a video at the bottom there that you guys can refer to later. So we'll talk a little bit about Parkinson's versus essential tremor because this is most of the reason why people get referred to us for tremor is this Parkinson's or not. Parkinson's tends eyes. You're going to try to see if they have any rigidity, any hypophonia, so if their voice is much softer, and then you're going to look at their gait as well. And then you might ask about some of these other things that we see with Parkinson's, like decreased ability to smell, constipation, sleep disturbances. A lot of these can come out before the movement issues ever come out. And then essential tremor, on the other hand, is going to be more bilateral and symmetric. So that would be more reassuring. There's not really going to be a rest component to it. Sometimes there will be a family history. It might improve with alcohol, and it can involve a lot of different areas of the body as well. If you are suspicious for Parkinson's, but you're not sure if there's some like overlap symptoms, Parkinson's is primarily a clinical diagnosis, but if you're kind of on the edge with it, you can get a DAT scan, so a dopamine transporter scan, which looks for dopamine activity in the basal ganglia. And if it's decreased, you're concerned about Parkinson's or a Parkinson's plus syndrome. And then you could also get a skin biopsy for alpha-synuclein. I do this a lot less just because it's more invasive, but that is another option as well. So management for these two is very different. Medical management of Parkinson's, you're mostly going to be focused on dopamine replacement, and the most common one that we use is Sinemet, which is carbidopa levodopa, but there are some other options out there as well. And then medical management of essential tremor, you're thinking about propranolol again as kind of your mainstay of treatment. You can also use primidone, but you have to be a little more careful in your older patients. And then Topamax and gabapentin have they don't work super well, but sometimes they work for some people. There is surgical management options for both of these as well. So DBS you can use for either. And then for essential tremor, you can also do a focused ultrasound ablation of the thalamus, which sometimes helps when it's really refractory. All right, moving on to neuropathy. Another super common consult. Why does this patient have numbness and tingling? So you're going to be thinking about the time course of the neuropathy. Has it been like slowly progressive over a long period of time? Is it more subacute or is it more rapidly progressing? And that's going to clue you into whether you need to be concerned about some of these other neuromuscular things or if it's just kind of like your run-of-the-mill neuropathy. Symmetric versus asymmetric. So is it kind of in both legs? Is it just on one side? Is it length dependent, meaning did it start originally in the toes and kind of work its way upwards? Or is it non-length dependent, meaning like did it start in the hands and then go to the feet? And then that would be a little bit more atypical. And then are there certain positions that bring out this neuropathy? So is it potentially like a compressive neuropathy, or is it potentially a spinal issue? And then you want to think about when you're doing your exam, what sensory modalities are involved. So is it pain and temperature primarily, or do they also have vibration and proprioception, which would be the large fiber nerves? Is there motor involvement? If there's motor involvement, you're starting to get more concerned about whether they need some other types of intervention. And then thinking about the distribution. So is it more radicular, meaning is it following the path of one of the nerves coming from the spine? Or is it in the same distribution as one of the peripheral nerves, like the ulnar nerve, for example, for a compressive neuropathy? Or is it a polyneuropathy? So it's kind of in like a more diffuse type of distribution. We talked about dot phrases. These are the dot phrases that we have at our institution that I find super helpful. So it has like the movement that you're testing and the muscle that's involved with that movement, and then like the peripheral nerve that leads to that movement, as well as the nerve roots. And so you can test all these different movements and find the commonality between all of the ones that are weak, and that helps you determine, is it an issue with potentially a peripheral nerve, or is it more of a radicular issue? So we have one for upper extremity exam, and then I'll just flash the one for lower extremity exam. You guys can go back to this later and review like the brachial plexus and all of that good stuff. Diagnostics that you want to think about. So labs, if you're dealing with just a very classic symmetric length-dependent neuropathy, you want to be sending an A1C, an SPEP, and serum free light chains, and a vitamin B12 as your basic labs. And then depending on their risk factors or other symptoms, you can send things like TSH, HIV, syphilis. There's like a whole host of other labs that you can think about sending. And then you can also get a test called an EMG NCS, or electromyography and nerve conduction studies. And this kind of helps confirm the pattern, localization, and time course and severity. So it kind of can help in a lot of different ways depending on what you're looking for. Like if you're not sure where the lesion is, it can help sometimes with localization. Oftentimes you'll see like that they have carpal tunnel, but you want to know how severe it is for the surgeons to decide if they want to intervene or not, then it can help in that case as well. And I think one thing that like I fully did not realize about these tests when I was learning about them was that for sensory changes, it really only picks up things that are past the dorsal root ganglion. So anything that happens before that, the sensory stuff might look normal on an EMG NCS. So spinal cord things and radiculopathies will look more normal. And if you're concerned about a spinal cord process, you want to be getting a spine MRI of the level that you're particularly concerned about. So management, really the mainstay is addressing the underlying risk factor and the underlying cause of the neuropathy, so diabetes, alcohol use, whatever it may be. But in terms of symptom management, you can think about some oral medications. The ones that you're going to reach for first are things like gabapentin or pregabalin. Your SNRIs, primarily, we're going to be using duloxetine here. And again, your tricyclics, so amitriptyline or nortriptyline. And these tend to work mostly for like the tingling part of it, the numbness, unfortunately, you cannot really treat. So people are kind of stuck with that. Topicals I really love because a lot of these patients are older and they're very sensitive to medications. So you can think about things like lidocaine patches or capsaicin cream, or Sarna lotion is like a menthol-based lotion that you can use. And some people find those really helpful. And then thinking about interventions, if there is like a herniated disc or radiculopathy, you can think about an epidural steroid injection if they're not getting good relief from other things or they have medication sensitivities. And then surgery if there's any motor involvement for spinal cord processes, or for any compressive neuropathies where the nerve just needs to be released. All right, cognitive complaints. So a lot of people will come in saying that their memory is not as good as it was before, they're not thinking quite as well. I think the big thing here is thinking about the time course and the progression of their cognitive symptoms. And the big thing is making sure you obtain collateral history from family members. If they have a real memory problem, they're not going to be able to give you very good information. And sometimes the family members are not at all concerned and the patient is, and then you're a little suspicious that there's not really anything seriously wrong with their memory going on. And then you want to be thinking about how impaired they actually are due to these cognitive issues. So they might be more in the mild cognitive impairment category, where they're still able to do all their activities of daily living, versus dementia, they may not be able to do some of their IADLs or ADLs anymore. And then you want to kind of pick out the patterns of what specific types of things that they are having trouble with to help you determine what they might have. So different types of dementia, I'm not going to read this whole thing to you, but the ones that you want to think about in the big major categories are Alzheimer's, which is a little bit more memory and visuospatial predominant. Frontotemporal dementia, you're going to get some behavior issues, maybe some language problems. Dementia with Lewy bodies is a little bit of a Parkinson's plus kind of thing, with some hallucinations involved. And then vascular dementia might be more like general executive dysfunction. So these are kind of clinical syndromes that we diagnose people off of. There is also a neuropathologic classification where we divide things into what we call the tauopathies and the synucleinopathies, and like the TDP-43 related diseases. But just to say, we're not very good at always getting these right, and they don't always match the clinical syndrome of the patient. So we're still trying to figure out how we can get better at that. Evaluating cognitive complaints, we kind of went through this already, and heard a really great explanation of the mental status exam. So you want to do a full mental status exam. You can look for other signs like the Lyria sequence or frontal release signs. And then you can do either a MoCA or a mini mental status exam. I think the MoCA is a little bit better and a little more detailed. And then oftentimes you're going to be sending these patients for formal neuropsych eval, where they can help you kind of determine the pattern of what specific cognitive domains they're having issues with. And then imaging, MRI can often be helpful, looking for patterns of atrophy. We talked about DAT scans already. And then for Alzheimer's specifically, you can do either an amyloid PET or do an LP and look at the phosphorylated tau and A-beta ratio. So management-wise, there's not a whole lot we can do, unfortunately, although there is some new stuff that's come out recently. So I will often counsel my patients on brain health, and in order to try to prevent the progression of the disease as rapidly. Some medications you can think about, I think donepezil is probably the one that we reach for the most often and first, but you're also going to be thinking about some of the comorbid symptoms you might have, so some psych symptoms or agitation. And then the big new thing in neurology is the amyloid therapeutics. So thinking about lecanemab and donanemab, this is where the amyloid PET and the LP become really important to do early on if you really do suspect Alzheimer's, because they may be candidates for these treatments. But we have very stringent selection criteria. There are some side effects that you can get from it that we have to monitor for closely. And then I think the only other thing I'll say about this is that you really want to stay on top of making sure the families have the support they need for that patient, and stay on top of getting them transitioned into any supportive care, nursing homes, or memory care units as they need. Okay, last one, epilepsy. So we talked a little bit about epilepsy diagnostics already. I think the big thing for a new diagnosis of epilepsy, you want to make sure you have a routine EEG for everyone, looking for any epileptiform like background activity and an MRI brain. You really want to make sure you get it seizure protocol. So you're looking for any specific lesions that may be the focus of the epilepsy. And then some other like testing that you may or may not get later on is getting a more long-term ambulatory EEG where they can just do this at home for a few days at a time with video if you're not sure if certain spells are truly seizures or not. They may do an epilepsy monitoring unit stay if you're trying to do this, or if you're trying to set them up for surgery or something like that. And then other imaging like a PET and an MEG also useful for surgical planning. And then classification-wise, the big thing that you want to determine is if it's focal or if it's generalized, and keep in mind that things that appear generalized can often start focal. And then there's aware, like focal aware seizures versus impaired awareness. In terms of thinking about anti-seizure medications that you want to keep your patient on long-term, there's going to be a lot of different things that play into it. But one of the big things is focal versus generalized, and that's why it's so important to determine, because certain medications only work for focal, while others work better in the generalized setting. And then you're going to be thinking about things like side effect profile. A lot of these are twice-a-day medications. Can the patient do that? Or some of them require a long up titration. If they are somebody who's going to stop their medications all the time, that's probably not the best. And then if there's somebody where they're kind of in and out of the hospital a lot, where they often need their meds converted to IV, you want to make sure they're on something that has an IV option. And then there's a lot of different mechanisms of action. And so if you have somebody on multiple, you may want to choose different mechanisms so that they have some additional synergistic effect from them. There's a whole lot of anti-seizure medications. You can go to this Continuum article to see the full list. I think the ones that I reach for the most are Keppra first, and then Vimpat, and mostly kind of in the inpatient setting because they're quick and easy with few side effects. But in the outpatient setting, lamotrigine is also a really great one, especially for young women or people with a psych background. There's also surgical management for epilepsy as well. So they can resect the lesion if there's a clear lesion that's causing this, but there's also some really cool neuromodulation techniques that we use. The newest one being responsive neurostimulation system. So it detects when a seizure is starting and gives a little pulse to try to stop the seizure from progressing. But you can also use DBS and VNS. And then just quick counseling for your epilepsy patients. So sudden unexplained death in epilepsy is a big concern. And so you want to counsel them that that is a possibility. They really want to be staying consistently on their medications. And then driving is also another big one for epilepsy. So different states have different laws. In Massachusetts, you can't drive for 6 months after you've had a seizure, but it's very different in other states. So you want to make sure you know the laws of the state that you're in, or any of the states that your patients might come from that are around you. Okay, that was my really quick breeze through of outpatient neurology. These are some general helpful resources that we all kind of put together if you're interested in learning more about any of these things.
Hey, awesome. Thank you so much. That was amazing and such a good, that was just an amazing boot camp overall. I'll pass it on to Maggie to wrap up.
Thank you to all four speakers. Like Hyung said, you guys did an amazing job. I learned so much. And I just want to highlight again the feedback form for all of our speakers in the bootcamp session in general. It'll automatically pop up at the end of this Zoom session if you haven't filled it out already. I put the link in the chat earlier. And speaker slides will be emailed to anyone who completes the survey and includes their email in the survey as well. The YouTube video is probably going to go up a little bit later. We're going to wait for all the boot camps to wrap up and then upload them all together. But yeah, let's give a warm welcome or a warm thank you again to all of the speakers. Have a great weekend, everybody.
Thank you, everyone.